I'm here to talk to you today about screening, brief intervention, and referral to treatment. I do not claim to be a physician and I'm not dispensing medical advice. I'm synthesizing available information from literature for the purpose of teaching the behavioral health professional about treating clients with substance use disorders. These are the resources I've used to make this PowerPoint slide. What you will learn: what is Sbirt? Why use Sbirt? What are some of the model characteristics of Sbirt? What's brief intervention and treatment guidelines? How do we administer Sbirt universal screening tools? What's brief intervention versus brief treatment? What's brief intervention motivational interviewing, key strategies and techniques? What are some brief treatment models we use after Sbirt? What are some brief therapy models? And what are some intervention models? Why use Sbirt? Sbirt is defined by SAMHSA as a comprehensive integrated public health approach to early delivery of intervention for individuals with risky alcohol and drug use. Screening and brief intervention and referral to treatment. Sbirt was originally developed as a public health model designed to promote universal screening, secondary prevention, detect early signs of hazardous use, have early interventions, and refer people to treatment for problematic or hazardous alcohol problems. What are some model characteristics of Sbirt? It is brief. It's generally done in an office setting in about 5 to 10 minutes. The interventions can be 5 to 12 sessions for brief treatments. The screening is universal. One or more specific behaviors is targeted. The services occur in a public health or a substance abuse treatment setting. It is comprehensive, and there's strong empirical research that it works. So again, I say it is brief. The initial screening is accomplished quickly in about 5 to 10 minutes. The intervention treatment components indicated by the screening results are completed in significantly less time than traditional substance abuse specialty care. The screening is universal. The patients, clients, students, and other targeted populations are screened as part of the standardized intake process. One or more specific behaviors is targeted: drug use, alcohol use, or smoking. The services occur in a public health setting or other non-substance abuse treatment setting. This may be an emergency department, primary care physician's office, school, etc. When Sbirt was first developed, it was developed for physicians and non-substance abuse treatment settings. However, today it is being used in substance abuse treatment settings as a modality for brief screening and assessment. It is comprehensive. The program includes a seamless transition between brief universal screening and brief intervention or brief treatment and referral to specialty substance abuse care. It is substantial in its modality, and there is experimental evidence that supports the model. Using the brief intervention and treatment guide, as defined by SAMHSA, the Sbirt program involves 1 to 5 sessions lasting 5 minutes to an hour. Brief treatment as part of Sbirt involves 5 to 12 sessions lasting up to an hour. Here we see here that we have the first thing that we're going to do is we're going to do the screening. So the screening takes place, that's the first modality. If we screen a patient and they happen to be low risk, then no further intervention is needed. If we screen another patient and they're moderate risk, then a brief intervention is needed. If we screen a moderate to high risk patient, then a brief treatment episode is needed. If we screen a severe risk or dependency problem, then we refer that patient to specialty treatment. Universal screening. Some common screening tools that we're going to use are the audit, the DAS, the MAST, the assist, the CAGE, the 5 Ps, the S2BI, and the brief screen. We will go over all of these in the PowerPoint presentation, and that the tools have been emailed to you for further use. Universal screening helps identify the appropriate level of services needed based on the patient's risk level. Patients who indicate little or no risky behavior, have a low screening score, may not need an intervention, as we saw on the slide before. Those who have moderately risky behaviors and reach a moderate threshold level for substance use disorders may be referred for a brief intervention. Patients who score high may need a brief treatment episode for further diagnostic assessments or more intensive long-term specialty treatment. Screening. The first thing we do is simply ask. Screening questions may be forms filled out in the waiting room. Computerized screening forms are being used increasingly. These questions are generally accepted by patients as part of the comprehensive health assessment that they take in their doctor's office. Initial screening helps determine which patients require further screening and assessment. Screening starts with questions that identify which patients have or ever used tobacco, alcohol, prescription drugs non-medically, or other illicit drugs. Screening through questions tends to be more effective for tobacco and alcohol than for drugs, and many people are less ready to admit the non-medical use of prescription drugs or illegal substances when they're screened on questionnaires in the waiting room. So we're going to go over a NIDA quick screen. The answers to the NIDA quick screen are once or twice, never, monthly, weekly, or daily. For alcohol use, men who drink 5 or more drinks in a day or women who drink 4 or more drinks in a day are considered at risk. For tobacco products, prescription drugs, and non-medical reasons and illegal drugs, all of these in excess of use will be determined on the NIDA quick screen, and positive answers will lead to further treatment interventions. This is the NIDA quick screen. Screening for drugs use allows clinicians to identify drug use early and prevent the escalation to addiction. Increase the wariness of the interaction of substance use with the patient's medical care, including potentially fatal drug interactions. Identify patients in need and refer them to specialty treatment. This is a standardized tool that you can use with your Sbirt because you want to identify if it's a beer this size, alcohol in the amount of 1.5 shots, which is this size, or an 8 to 9 ounce malt liquor, or maybe they're drinking 5 ounces of wine, and we want to know what size and what quantity they're drinking. So please keep this chart handy when you're asking patients what kind of drinks and the amounts that they are drinking. On the NIDA quick screen, the question for alcohol use is, in the past year, have you often tried using the following? Alcohol. For men, 5 or more drinks a day. For women, 4 or more drinks a day. Never, once or twice, monthly, weekly, daily, or almost daily. For tobacco, in the past year, have you ever used the following tobacco products? Never, once or twice, monthly, weekly, daily, or almost daily. For prescription or illegal drugs for non-medical reasons, never, once, twice, monthly, weekly, daily, or almost daily. And for any other illegal drugs, it's never, once or twice, monthly, weekly, daily, or almost daily. The answer of daily or almost daily is going to indicate that the person has a substance use problem. Monthly, they probably don't, but they might need a brief intervention. Weekly, they would need some brief treatment episodes. Once or twice or never, we're going to provide them with another brief education session after we've screened them. Another tool we can use is the CAGE. The CAGE is used when you are thinking about drinking or drug use. and includes the use of prescription drug use other than those prescribed. The first question is, have you ever felt that you ought to cut down on drinking or drug use? The answer is yes or no. Have people been annoyed by criticizing your drinking or drug use? Answer yes or no. The third question, have you ever felt bad about or guilty about your drinking or drug use? Yes or no. Have you ever had a drink or drugs first thing in the morning to steady your nerves or get rid of a hangover? Yes or no. One or more positive responses is a positive screen for substance use disorders, and further therapy should be done, probably sending the patient for a few brief therapy sessions. The Audit C is a 3-item screen that can help identify persons with harmful alcohol use disorders. It's a modified version of the 10-question audit screen. The first 3 questions are, have you had a drink containing alcohol? If so, how often? How many standard drinks containing alcohol do you have on a typical day? And how often do you have 6 or more drinks on one drinking occasion? To score the audit C, the answers are never, monthly or less, 2 to 4 times a month, 2 to 3 times per week, 4 or more times per week. Men with a score of 3 or more are positive for alcohol use disorder, and women with a score of 4 or more are positive for alcohol use disorder. Now we're going to go over brief intervention and brief treatment. The goal of brief treatment is 5 to 12 sessions. It's to change not only the immediate behavior or thoughts about risky behavior, but can address long-standing problems of harmful drinking and drug misuse and help patients with higher levels of their disorder to learn about more long-term care options. Patients are provided with brief treatment in order to intensify specialty treatment depending on their level of risk, including a validated pre-screen. The majority of patients who report minimal or no problems with alcohol or drugs may be an ideal group for primary or universal prevention activities for maintenance of non-risky use or abstinence. The goal of brief intervention is to educate patients and increase their motivation to reduce risky behavior. Brief intervention and motivational interviewing. Motivational interviewing was developed by Rollinick and Miller. The concept of motivational interviewing evolved from experience in the treatment of problem drinkers and was first described by Miller in 1983 in an article published in a behavioral psychotherapy magazine. These fundamental concepts and approaches were later elaborated by Miller and Rollinick in 1991 in a more detailed description of clinical procedures. Motivational interviewing is the technique in counseling that is used to elicit information from the client that is both directive and client-centered. This style of counseling helps clients explore how they can change their beliefs about what they are going through in terms of their own denial, rationalization, projection, and transference issues. The key strategies of motivational interviewing. Motivation to change is elicited from the client and not imposed from without. Other motivational approaches have emphasized coercion, persuasion, constructive confrontation, and the use of external contingencies. Such strategies may have their place in evoking change, but they are quite different in spirit from motivational interviewing, which relies upon identifying and mobilizing the client's intrinsic values and goals to simulate behavior change. Strategy 2. It's the client's task, not the counselor's, to articulate and resolve their own ambivalence. Ambivalence takes the form of a conflict between the two courses of action, indulgence versus restraint, each which has perceived benefits and costs associated with it. Many clients have never had the opportunity of expressing the often confusing, contradictory, and uniquely personal elements of the conflict. For example, If I stop smoking, I will feel better about myself, but I also will put on weight, which will make me feel unhappy and unattractive. It's the counselor's task to facilitate expression of both sides and the ambivalence impasse and guide the client towards the acceptable resolution that triggers change. Direct persuasion is a non-effective method for resolving ambivalence. It is tempting to try and be helpful by persuading the client of the urgency of the problem about the benefits of change. It is fairly clear, however, that these tactics generally increase client resistance and diminish the probability of change. The counseling style is generally a quiet and elicited one. Direct persuasion, aggressive confrontation, argumentation are the conceptual opposite of motivational interviewing as illicitly prescribed in this approach. To the counselor accustomed to confronting or giving advice, motivational interviewing can appear a hopelessly slow and passive process. The proof is in the outcome. More aggressive strategies that are guided to confront the client easily push the client into making changes that they're not ready to make, and they may relapse quicker. The next key strategy is the counselor's directive in helping the client to examine and resolve their ambivalence. Motivational interviewing involves no training of the clients in behavioral health coping techniques, but rather helps them make a personal viewpoint that will help them motivate towards change. Once that has been accomplished, there may or may not be the need for any further interventions or skill training. So we are directive in helping them making choices and changes which will affect their health for the long term. Readiness to change is not a client trait, but a fluctuating product of interpersonal interaction. The therapist is therefore highly attentive and responsive to the client's motivational signs. Resistance and denial are not seen as client traits, but as feedback regarding therapist behavior. Client resistance is often a signal that the counselor is assuming greater readiness to change. And if that's the case, then it's a therapist's cue to modify motivational strategies. The next key strategy that we're going to explore is the therapeutic relation is more than a partnership or companionship. It's rather than expert recipient roles. The therapist respects the client's autonomy and freedom of choice regarding his or her own behavior and value system. So the client is engaging with the therapist as a partner to motivate towards change. A motivational example is outlined on this page, but the key to motivational interviewing is to be able to listen without imposing the counselor's own thoughts and viewpoints onto the counselee. The counselor gathers information by asking open-ended questions of the counselee and giving feedback by using reflective listening techniques. Once the counselor reflects the counselee's emotions and gives feedback to the counselee is impacted empirically. Empathy, not sympathy. Empathy is in giving your compassionate attention to another by verbally stating their feelings and needs. Empathy requires the ability to be comfortable with the uncomfortable emotions and witness the suffering of others without trying to get them out of it. Empathy cultivates trust because the person could be heard deeply by another and therefore gain greater access to their own inner wisdom. In authoring empathy, we are not indicating agreement or disagreement. Empathy elicits change. Sympathy is the opposite. It's a feeling of pity or sorrow for another person. Sympathy comes alongside and joins with our own emotions, creating transference or countertransference issues for the clinician and the client. Brief treatment. The goal of brief treatment, which usually is 5 to 12 sessions, is to change not only the immediate behavior or thoughts about a risky behavior, but also to address long-standing problems about harmful drinking and drug misuse and help patients with higher levels of disorder obtain more long-term care. Brief treatment is sometimes called brief intensive intervention. It's a specialty outpatient treatment modality. Brief treatment is a systematic, focused process that relies on assessment, patient engagement, and implementation of change strategies. Brief treatment. The selected criteria for brief treatment is dual diagnosis issues with coexisting psychiatric disorders, developmental disabilities, the range and severity of presenting problems, the duration of abuse, availability of familiar and community supports, the level of client motivation, the clarity of a client's short and long-term goals, the client's belief in the value of brief therapy, and the determination of the number of clients needing treatment at any given time. Brief treatment criteria are derived from clinical experience. Characteristics of brief therapies or treatment: they are problem-focused or solution-focused. They target the symptom and not what is behind it. They clearly define goals related to a specific change. They should be understandable to both the client and the clinician. They should produce immediate results. They can be easily influenced by the personality and the counseling style of the therapist. The therapeutic style is highly active, empathetic, and sometimes directive. Responsibility for change is placed on the client. Early in the process, the focus is to help the client have experiences that enhance self-efficacy and confidence that change is possible. Termination is discussed from the beginning. Outcomes are always measurable. Brief treatment targets: learning to schedule and prioritize the client's time, expanding a sober support system, socializing with recovering people or learning to have fun without substance abuse, beginning skills exploration or training if unemployed, attending AA or NA meetings, giving up resentments or choosing to forgive others and self, staying in the here and now, developing a relapse prevention plan. Brief therapy criteria: they are either problem-focused or solution-focused. They target the symptom and not its causes. They clearly define goals related to specific changes or behaviors. They should be understandable to both client and clinician. They should produce immediate results. They can be easily influenced by the personality and counseling style of the therapist. The brief therapy models that we are going to go over are supportive expressive therapy. Developed in the 1980s, supportive expressive therapy, the client is helped to identify and talk about core relationship patterns and how they relate to substance abuse. That's something that we do in our treatment centers today. Psychodynamic therapy. This is the type of brief therapy that deals with a time-limited focus on defense mechanisms, addictive behaviors, identifies triggers, coping skills, and relapse prevention. This is another modality that is used effectively in treatment centers. Brief cognitive behavioral therapy. CBT combines cognitive and behavioral therapies and has strong empirical support for treating mood and anxiety disorders. The basic premise of CBT is that emotions are difficult to change directly, so CBT targets emotions by changing thoughts and behaviors that are contributing to the distressing emotions. Solution-focused brief therapy is a form of brief therapy that focuses and resolves problems with a simple behavioral approach that is clear and solution-focused by asking solution-oriented questions. CBT group therapy is the CBT approach that focuses on the group's attention and self-defeating beliefs relying on the group members to identify such beliefs in each other. All are effective as brief therapy models. The criteria for longer care treatment is failure of previous or shorter treatment, multiple concurrent problems, severe substance abuse or dependence, acute psychosis, acute intoxication, acute withdrawal, cognitive inability to focus, long-term history of relapse, many unsuccessful treatment episodes, low level of social supports, and serious consequences related to relapse. Here we're going to look a little bit at the stages of change. The first stage of change is the pre-contemplation. And we look at pre-contemplation, and we look that pre-contemplation is the stage that we motivate towards when we're not thinking about changing a problem. We're in the moment, we're staying the same. The next one, I went the wrong way with the arrow, so we'll go this way, is contemplation. Contemplation is the stage of change that we're going to do when we're thinking about changing a problem. We're going to contemplate it. We're going to weigh the costs. In preparation, we start to prepare to make changes. Things are bothering us about this problem. Our substance use has caused us some things in our life, some losses in our life, maybe family, maybe friends, maybe home, maybe job, maybe legal issues. In action, we're in change. We start to take the steps to change. We are solution focused at this point, and we're engaging in recovery services. Maintenance is the stage which we stay in when we're working on our problem, and this is an open-ended stage. When we move off of this and we go to the big R, which we know as relapse, we have to start the stages of change all over again. This is a brief screen. It's given to adults ages 18 and older. One validated question for adult alcohol use and one validated question for adult drug use. Positive responses warrant further screening. It includes a PHQ-2 screening for depression. You can find this tool in your packet. The audit is given to adults ages 18 and older when positive on alcohol screenings. A full screen assesses the quantity of alcohol use and related consequences. It includes illustrated examples of standard drinks and extra questions about alcohol treatment. The Mass Michigan Alcohol Screening Test was developed in 1971. It is one of the oldest and most accurate screening tests available, effective in identifying dependent drinkers with up to 98% accuracy. Questions in the Mass test relate to self-appraisal of social, vocational, and family problems associated with drinking patterns. The Mass is one of the most widely used measures for assessing alcohol abuse. The measure of the 25-item questionnaire is designed to provide rapid and effective screening for lifetime alcohol-related problems and alcoholism. The DAST, very similar to the MASS, was developed in 1982 and is a 28-question test that is sensitive to screen for drugs of abuse other than alcohol. It's given to adults 18 and older, and it's given when positive on the drug question on the brief screen. A full screen that assesses consequences related to recreational drug use. It includes extra questions about type of drugs, injection of drugs, and drug treatment. The S2BI is given to adolescent patients aged 12 to 17 at least once a year during any medical visit. The full screen that measures frequency of tobacco, alcohol, and drug use to indicate a possible substance use disorder. Includes supplemental craft questions, includes the PHQ-2 and the PHQ-9, which is the modified screening for depression in adolescents. The 5 Ps are given to pregnant females And 8 questions screen for the use of tobacco, alcohol, and drug use, as well as depression and intimate partner violence. The assist is administered to adult patients ages 18 and older through an interview with a health professional, a full screen to assess the severity of substance use. This version is only modified to address drug use only. The PHQ-9 is an easy-to-use patient questionnaire that is self-administered version of the F.R.A.M.E.S diagnostic instrument for common mental disorders. The PHQ-9 is the depression module, which scores each of the 9 DSM-5 criteria as 0 to 3, and it has been validated for use in primary care settings. Now, when we've done all the screenings, we have to give the patient feedback on the results of those screenings. So here we will use the FLOW model. FLOW talks about feedback. When we use the Audit C, the Audit, the DAST, any of the tools that we've discussed, we want to give the patient feedback. So we tell them what their score is. We listen and elicit information from them. How do they react to that? And then O is the options, the goal setting, which is 1 to 5 minutes. Example, an Audit C can range from 0 to 12 for hazardous, harmful, risk use of alcohol. The Audit can range from 0 to 40 for hazardous, risk use of alcohol, and the DAST can range from 0 to 10 for drugs of misuse. Give the result. Your score was 5 on the DASH, which places you in the category of medium risk or harm for use of drugs. What do you think of that? Intervention models. Vernon Johnson discovered the intervention model in 1971. There was not one major life-altering event in this model that caused people to quit. The majority of their quitting involved several non-life-threatening events involving spasms, family fights, or another illness caused by addiction. When seeking sobriety, something was easily detected. It was a forced decision resulted from small life-altering events. When sobriety was not sought out, the small life-altering events collided quickly and caused problems and even death. There needs to be a well-thought-out and defined plan to help the addict to see what the consequences could be if sobriety is not sought. The F.R.A.M.E.S is a soft intervention. We give feedback about personal risk, responsibility to change, advice or suggestions to change. We give a menu of change options to our clients. We express empathy. We support self-efficacy and optimism. So how does the Sbirt process work? We assess the level and pattern of use, whether they are dependent or the severity of their risk. We provide feedback about drinking, drug use, and consequences. We support their goals, explore ways how they can change. The responsibility always falls on the person using alcohol or the family. Family involvement, if that happens, we give feedback, support the efforts, successes, and we support boundaries. We follow up. We monitor the patient and family progress. We troubleshoot any problems, and we always support successes. So going back to the Johnson model, we're going to get a little heavier into this model because it's very effective for helping the addiction professional be able to discuss problems with the client. So the Johnson model is teamwork, planning, focus on care, talk about the addiction only, What is the evidence? What is the primary goal? And what are some of the treatment options? The team is organized by the counselor that specializes in intervention. It also includes family members, colleagues, loved ones, as well as friends who are in the substance abuser's life. The planning. During this stage, the time of the intervention is determined as well as exactly what is going to be said through the intervention letters. Focused on care. This is the component that is imperative and must be followed throughout the whole process from beginning to end. There should not be a time when the addict or alcoholic is being yelled at or even condemned. Addiction only. During the process, the only thing that should be talked about is the issue of addiction, not anything else from the patient's past. The primary goal is treatment. As a team, the results of the intervention must be agreed upon treatment goal. This should not be explained or discussed as a punishment, but rather this is an effort to help improve the person's life. Evidence. When the people who are doing the intervention, there must be evidence or proof provided in the letters. All the past events should be spoken of and described in every detail. Treatment options. Ideally, each intervention will end in the addict seeking out treatment. In order for this to happen, the team must put together 2 or 3 different treatment options when it comes to treatment. The intervention schedule. It's an initial call from family members when they're in full crisis mode. They fill out an intervention assessment with the counselor. They schedule a meeting with family members, usually 2 to 3 hours in length. Provide educational resources. Verify insurance or payments if applicable. Discuss roadblocks or successes of the intervention. Instruct the team on how to write love letters to the family member. What do you love about that family member? What are some of the things that disturb you about their addiction? How they still accept the person and hope they will respond to the help offered. Their hope for this person for a bright future. The invitation model. Invite family member to join the intervention process. It's a systematic model. It happens over a few sessions. The surprise model is when family members arrange and surprise the family member with the intervention. This is the least successful model, although maybe some television networking shows it being highly effective. It is really least successful. The systematic model over a few sessions is usually more successful for the client and family. Right now, you're going to have some practice cases. So those are provided for you. I thank you for spending this time doing Sbirt with me today. And I just ask that you fill out the practice cases and submit them so you can get your CEUs for your continuing education units. Have a great day and good luck in doing all the Sbirt screening and brief intervention and referral to treatment with your clients. Thank you.